hypotension, lightheadedness, hit the red button, stop the test. It's positive, but it's not the point of it. I have to be able to exercise. It's cheap. It's first. It's easy, as long as I can exercise and read the EKG for ischemia. Now, what happens, though, when the person has an EKG that is at baseline abnormal? What happens when they already have ST abnormalities? Can you give me a condition that people, or a state, or circumstances in which people always have ST segment depression? Previous MI, you might have some abnormalities. Or hypertension, left ventricular hypertrophy. Left ventricular hypertrophy can give you ST segment depression all the time. Hypertension for left ventricular hypertrophy. Maybe the person has left ventricular hypertrophy all the time. Give me another circumstance. Excellent. Now, what drugs give ST segment depression? Digoxin. They're on digoxin. You can't do a stress test for regular EKG stress test because they're always going to have ST depression. They're always going to have ST segment depression. So therefore, you can't use this. If you already have depression, how can you say, I will use that to detect their abnormality? That was like saying, well, you have a positive test now. Digoxin, left ventricular hypertrophy, a pacemaker spike, a left bundle branch block. You have something that looks like ST elevation all the time. The point is, what do you do when you can't read the EKG? I can't interpret. I need two things for a regular stress test. One, I need to be able to exercise. Two, I need to be able to read the EKG. If I can't read the EKG for ST segment depression, because LVH and pacers, and where you have a pacer spike that goes spike, spike, it's always abnormal. What test would you use then? What else would you use to image the heart? You could use an echo. I need to do regular stress tests to be able to exercise and read the EKG. If I can't read the EKG, I need to find another way to look at my heart. I can look at the heart with a stress echo, or what other imaging? Other imaging is thallium. Thallium. The other imaging is thallium. Stress echo or stress thallium. Stress echo or stress thallium. I go walking on my treadmill, but I inject thallium or I do an echocardiogram right afterwards. How would I detect the abnormality on the stress echo? What would I see on the echo that would tell me that there's ischemia there? Ejection fraction? Yes. Normally when you exercise, what happens to your ejection fraction? It normally should increase. So, yeah, one is ejection fraction, but that's not the major thing. What? Motility. Motility. What do you see when the person has ischemia? The heart is beating, beating, beating. What do you see when they have ischemia? Stop getting fascinated by my hand. Do that. What do you see? Hypokinesis or decreased motion? No, it means the same thing. I didn't. You said it was different. You see hypokinesis or decreased motion, or dysmotility. It's the same thing. Dis means bad or evil. Motility, motion. dysmotility, low motility, abnormal motion, whatever ways you learn to say, it no move so good. She no move so good. So the heart should normally contract, and then the abnormal part stops contracting. Normally everything should move, and then what ends up happening is that the ischemic part does not move. And that's what you see. You end up seeing decreased wall motion, dysmotility, hypokinesis, whatever way you learn to say, she no move so good, she no move so good. Now that's for ischemia. For ischemia, you exercise and you see the dysmotile abnormal motion part with the ischemia. But what would it look like if it was infarcted? That is to say, dead. If it's infarcted, what would you see if it was infarcted? No motion? Or akinesis? Same. Ooh, can't fool you anymore. Yes, akinesis, no kinesis, no motion. Yes, keep writing that down. Keep writing that down. I like, you can't see all the scribbling. Can you get a shot of all the scribbling? Okay. This is why I tell people, that's why I said, trust me, trust me, trust me. You know what I mean? I was like, don't read the notes. It hasn't changed. In other words, 25 years ago, when you got ischemic, the heart didn't move. I have something new to tell you, something brand new. When the heart becomes ischemic, just discovered, it doesn't move. And I have the latest, newest thing, which you're writing down right now, that when the heart is dead, it doesn't move. Ready? The first part of this is what you're writing down. What did you learn in class today, honey? I learned that dead things don't move. Dead things don't move. Clear? I like that. You get akinesis if it's dead. Dead things don't move. Okay? Now the difference is that the infarcted thing is never moving. The ischemic thing is moving at rest. And then when I go walking on my treadmill, then it stops moving when I've been exercising. At rest, it moves. At exercise, it becomes ischemic and stop moving. This is going to be very important in a lot of things. Ralph Waldo Emerson, in his essay on self-reliance, says that the only real satisfaction comes from the triumph of principle. And the principle here is that ischemia causes low and decreased motion. That's also why people become short of breath when they become ischemic. It's also why people develop RALS when they become ischemic. It's also why ischemia leads to pulmonary edema, because it doesn't move as well when you're ischemic. We'll say it in a different form at 11:23 this morning, but it's going to be the same idea. Now, stress thallium. If you are a myocyte in the heart, what does thallium look like to you? If you're a myocyte in the heart, what does thallium look like to you? Myocyte. You're hanging out there, actin, myosin. Looking over the next myocyte, How you doing? All right. Yeah, Purkinje fibers are never working right. You know what I mean? You're here, actin, myosin. Yeah. Hey, you been up to the AV node lately? Nah, I didn't get there today. All right. What does thallium look like to you if you're a myocyte in the heart? Capillary comes by. Hey, what's for breakfast this morning? I don't know. How's the oxygen? Same as always. 21%, 21%. Never changes. Thallium looks like potassium. Thallium looks like potassium. So if you're a myocyte in the heart, you will pick up potassium because of the potassium, sodium, ATPase. If two things happen, one, you are alive. The cell has to be alive, not dead. You'll pick it up. Two, you're perfused. The capillary can deliver the thallium. alive, not infarcted. Because you can't incorporate it if you're dead. 2, perfused, not ischemic. So if you are 1, alive, 2, perfused, you'll pick up thallium. Because thallium looks to you like potassium. I love it when you do that. I love it when you're thinking. So how will you detect the abnormality? This is the heart, apex. How will you detect the abnormality on the stress thallium? You have this ischemic side. You have this ischemic side. And you have a normal side. And you get the thallium getting injected. And how will you detect the abnormality if there's ischemia? Huh? Absence of thallium. Decreased thallium. Decreased thallium uptake. Because what will happen is that the normal side will pick up the thallium. The normal side will pick up the thallium. The normal side will pick up the thallium, and the ischemic side won't. So the normal side will pick up the thallium, and the ischemic or infarcted side will not. So you have decreased thallium uptake. You have decreased thallium uptake to distinguish the case. And that's how you will detect the abnormality. Decreased thallium uptake. Decreased thallium uptake in ischemia or decreased thallium uptake in infarction? Both. Both, because ischemic means no perfusion. No thallium coming by. Infarcted means you're dead. And your sodium, potassium, ATPase doesn't work. So both ischemia and infarction will have decreased thallium uptake. How will you tell them apart? Echo, no. Good thought, good thought, good thought, but that's not it. You go walking on your treadmill, and you inject the thallium. And there's no thallium uptake if you're infarcted. And if you're infarcted and there's no thallium uptake, and then you sit and you rest, and you rest 2 hours, 4 hours, and you scan them again. How will the scan be different 4 hours from now if it's infarcted? No change. But if it's ischemic, it will fill in over time. So over time, ischemia will change with reperfusion, and infarction won't. Because if you're dead now, 4 hours from now, you will still be dead. Doesn't change. But ischemia will change. But infarction will not change. Okay? That's how you tell. Now, these mostly are when you can't read the EKG. Fine. So you go have the patient, and you're going to send this woman down for her stress test. You're going to send down the woman for the stress test, and you notice, like Walt Whitman says, there is a lot of her, and all so luscious. And you notice that she's 5 feet tall and 325 pounds. And it turns out that she's 5 feet by 5 feet by 5 feet. And she rolls into your office. And you're going to say to put her on a treadmill, but you notice that she's only got one leg anyway. She's too obese to live, she has one leg, and you're getting ready to do the hopping stress test. When you notice that she gets claudication, because she's got tremendous peripheral vascular disease. So she starts to hop, and she gets terrible pain in her calves, and her calves are burning, and she can't hop so well because she's got such bad diabetic foot ulcers that her foot is all ulcerated up because of diabetic foot ulcers, claudication with peripheral vascular disease, too obese to live. And then you notice she's so short of breath at rest from her COPD, from her 30-pack-year smoking history. She's got COPD and she can't exercise. She gets claudication from taking a little bit of exercise. She's got one leg, no legs. You'll do a crawling stress test. Grow. And you notice she's got Takayasu's arthritis and she's got no arms. So the point is, you can do it two ways. You can sit there and memorize it like this and go, claudication, peripheral vascular disease, diabetic foot ulcers, obesity, amputation, one amputation, two amputation, vasculitis. Or you can simply say, what makes it so you can't exercise? So why memorize 40 things that make it so you can't exercise? Now, here's how to learn. If you start to memorize all of the list of things that make it so that you can't exercise, you'll be able to eventually pass. But the problem is, people who write questions will always be able to find something that you didn't memorize. If you learn the question, what makes it that you can't exercise, you become independent of circumstances. Become independent of circumstances. Because no matter what circumstances, you're saying, does this mean they can't exercise? You're independent of circumstances. That's one part. So that means you can handle anything that comes. The other part of it is disk space. Hard drive should get 40 gigabytes, born with 1. And you can learn claudication, peripheral vascular disease, diabetic foot ulcer, COPD, alpha-1 antitrypsin deficiency. Or you can just say, the question, what makes it so that they can't exercise? Much less to memorize, isn't it? And it's easier. It feels better. It's not only going to get you a better result, it feels better. Feels easier. You could learn LVH, digoxin, pacemaker, but you know what? Your test will have procainamide on it. Procainamide causes down scooping. Or maybe they'll give you something else that I can't anticipate. But if you simply say, why can't I read the EKG? Why can't I read the EKG? And what makes it so that I can't exercise? When I can't exercise, what test do I do? Obesity, claudication, peripheral vascular. What test will I do when I can't exercise? Huh? Diprotamol? Diprotamol or Persantine? It is the same. It is the same. A diprotamol or Persantine thallium. Diprotamol or Persantine thallium. Or what? Dobutrex is the manufacturer's name for dobutamine with a echo. Dobutamine echo. Dobutamine echo. Dobutamine echo or a Persantine thallium. Now, most of you at your level will say, well, how do I know when to choose the stress echo or the stress thallium? I am very specifically labeling these as saying either or. You cannot be asked to choose between these. They have the same indication. When can't you read the EKG? They can't ask you to choose between them. That would be like saying a person has tuberculosis. Do you start the INH or the rifampin? It's like, huh? No. Do you pay the phone bill or the electric bill? No, both. Okay? So you can't choose between these either because these are pharmacologic methods of simulating exercise when you can't exercise. How do I determine if someone's had sufficient exercise when they go walking on the treadmill? How do you determine? Huh? Heart rate. What's your maximum heart rate? Yeah, yours personally. 120. How old are you? 27. What's his maximum heart rate? He's 27 years old. Ah. Now, I didn't learn it in medical school either, but I did learn it in those aerobics Did learn it in aerobics classes. Okay? So even if you didn't learn it in medical school, little chart on the wall. Okay, ready? Leg lifts, girls, right there. Oh, 6-second pulse. Check a pulse. 220 minus your age. Your maximum heart rate is closer to 190. Do you know that? Yeah, 220 minus your age. So a maximum stress test would go to 85% of that. So we'd really be looking for a stress test for you to go to 160 or 170. 220 minus your age. So your maximum heart rate is 193, and 80% of that, 85% of that is closer to 165, 170. 220 minus your age. That's maximum heart rate. Your maximum heart rate would be 120 only if you were 100 years old. See? It's good. Now you see. Now look. You see this? He could take two ways to do this. He could feel all confronted and all this and get all be bothered and who the hell is this guy? Or he could just say, he'll never forget this. You know what I mean? He'll, bang, he'll never forget this. Even if he wants to. I can't get this out of my head. My heart rate. I should be going around 160 all the time. You could. The point is heart rate. Listen, that's why exercise tolerance goes down when you get older. Your ability to have variability in your heart rate and in your blood pressure. That's why, like our guy George Foreman, what is he, 48-year-old boxer? That's why it's such an accomplishment, because that guy's maximum heart rate, just by being 48, is 20 beats less, 25 beats less than the younger guy who's a 25-year-old fighter. Just he can't, you know, that's why all the things about geriatrics, everything, you can't adjust your blood pressure or your pulse or your respiratory rate as avidly. You can't exercise persantine thallium. How will you detect the abnormality on the persantine thallium? By looking for decreased thallium uptake. And on dobutamine echo, you will see decreased wall motion. And the reason you will see decreased wall motion, and the reason you will see decreased thallium uptake is because these drugs pharmacologically simulate the effect of exercise. Persantine dilates blood vessels, dilates coronary arteries. If you have a normal heart, you should have greater flow of blood. More blood, more thallium picked up. Because thallium looks to the myocytes just like potassium. More dilated flow, more potassium delivery, and more thallium pickup. Dobutamine echo increases contractility and can provoke ischemia. And you should see decreased wall motion. You can't ask to be choose between these. And you might say, well, why not do these for everybody? And the answer is, real exercise is always better than simulated. No matter how much you can artificially create the experience, it's not as good as the experience of real exercise. Now, when I told you about the 5-foot lady with no arms or one arm or no legs, what about that thing about using the bicycle ergonometry? What about using that, the bicycle thing, if somebody can't exercise with their legs? What about using the old bicycle thing? Bueno or no bueno? Good or no good? Yes or no? Thinky, think, think. Don't look at my face for the answer. You're looking for my face for the answer. Look into your own soul. Good or no good? Not good. I don't know is an honest answer. I accept that. Not good. Not good. Not good. Why not? What's wrong with the bicycle ergonometry? There's something inadequate about it, about doing that, why that's never going to be the answer. It's never going to be the answer. Why not? Good, good. I love it when you tell me that's good. That's good. Thinking, thinking, thinking. That's great. I can feel the norepinephrine crossing your synapses. Why not? Not enough of an aerobic exercise is the right answer. How do you tell if there's sufficient exercise when you go walking, walking, walking on your treadmill, treadmill, treadmill? Heart rate. It's not enough exercise to get the heart rate up. Because no matter how hypertrophic you might become, it's still not as thick as my thighs. You see the point? No matter how much you might beef up in a particular day with your creatine, it still doesn't equal the amount of muscle mass as the thighs. And blood supply and the amount your heart rate works has to do with how much beef you have to supply. And this is much less beef to supply. This is much less than your thighs. So you can't stimulate the effect of exercise. It's just not enough muscle mass. So when you see bicycle ergonometry and it says, what is the next best step? It's always wrong. It will be the wrong answer in the question. Now that's the other thing that's essential here. That's what a regular book can't give you. The regular book does not tell you, don't answer this and this is wrong. It just tells you what's right. And if you think about it, if you're looking at the board question, there's only a limited number of things that could be in the wrong answers. Stress test, these types of stress tests, well, that's A, B, C, D, E right there. But I just told you that they won't ask you to choose between these. They won't ask you to choose between these two or between these two. So bicycle ergonometry is wrong. Insufficient exercise to stress the heart. Okay. So back to Our Lady. Her EKG is normal. Not enzymes in office. Not enzymes when people not have chest pain now. No. Wrong context. And we'll tell you that her stress test is positive. Her stress test shows ischemic heart disease. What will you do for her? What's the next best step in the management of this patient when her stress test shows positive now? Angiography is a good answer. What would you do? Angiography? Regular stress test. I'll tell you, a regular non-thallium stress test showed ischemia. What would you do next? Cath or angiography? Well, cath is what you do to get an angiography. That's how you do an angiogram. You catheterize them, you squirt in dye, and that's the angiogram. And angiogram and catheterization is the most common wrong answer. I tell you that this woman comes in with chest pain. I tell you she's had pain. I tell you that she's been having chest pain in her chest. That's why we call it chest pain. And I tell you that she's got a positive stress test showing ischemic heart disease. She's still got I still left all those horrible risk factors on her. Why is angiogram incorrect? Not correct. Can precipitate an MI. Good thought, but it doesn't. Angiography is in. First of all, what was my question? Did I say next step? You sure I said next step? Next best step? Or is that what I said? Or did I say the next step in diagnosis? What did I say? Next step in diagnosis? No, I said the next step. Did you think I meant next step in diagnosis? It's okay. It's all right. I still love you anyway. It's okay. Did you think I meant next step in diagnosis? Yes, you did. Some of you think I did. Some of you said, no, I didn't think you said that. I still think you should get the angiogram. Okay. But some of it will be this. What did I say? Now, the next step in diagnosis is an angiogram. The most accurate diagnostic test is an angiogram. But I didn't say that. I said, what is the next step? What would you do? Action, management. That could be either a test or a treatment. So it doesn't mean anything. Step, action, management. And the point is, what is the next step in management? Action, do. What you going to do now, Doc? Yo, what's up? And the answer is, no. You're not getting it. You know why you're not getting it? Because you're still relating it to like it's a patient that doesn't exist. So until you can develop compassion, which is a highly evolved spiritual condition, what you want to do is extend your narcissism. So you say, well, I can't really feel what this person feels, but I'll tell you what, if this was me, and you told me that I had ischemic heart disease, and I had chest pain, I'd like some treatment before I die of a heart attack. Oh. Hi, we're looking for Mrs. Smith. She didn't show up for her angiogram I scheduled 2 weeks ago. Where is she? She's dead? Why? Oh, I didn't give her any medications. Oops. I hate that when I keep omitting medications to people who have chest pain and ischemic heart disease. Ouch. Did you skip the medications and go straight for a treatment? You're a bad boy. Because it doesn't change it. Okay, so what medication should she get? She should definitely get aspirin. She should get aspirin. She should get aspirin. What else should all people like her get? She's got pain. If somebody's got pain, they should get nitrates. How much do the nitrates lower the mortality? They don't. They don't lower mortality. Aspirin lowers mortality. She can get aspirin. Nitrates. What else should everybody in her condition get? Beta blockers. Yeah. Yeah, beta blocker, man. Beta blockers. Yes, she should get beta blockers. What else should everybody get? ACE inhibitors. ACE. No. No, not everybody should get ACE. Now, she should get ACE because she's got diabetes and hypertension. And diabetics with hypertension, yes, because of this, she should get ACE. But what if we get rid of these risk factors? Let's get rid of it. Now, did you get that? Diabetes and hypertension means ACE inhibitors. But let's get rid of her risk factors. You see, the reason I'm saying no is because I know you were not giving her the ACE inhibitors based on the diabetes and hypertension. You were saying to give it because of the ischemic heart disease. Let's change her back to a woman with no past medical history. Normal EKG. Stress test shows ischemia. Aspirin, nitrates, beta blockers. ACE inhibitors are for diabetic hypertensives, but you don't have to add them for every person with stable angina unless there is... Huh? I can't hear you. I did that. Congestive heart failure? Just say, yeah, that's it. That's how to get honors in a fourth-year medical student rotation. You don't get the right answer. And as soon as somebody says it, the right answer, congestive heart failure, you go like this. Yeah, I was just about to say that. You know, I was just going to say that. It's angina with CHF. Or low ejection fraction. Or decreased wall motion. Which one? They're all the same. Es lo mismo. It's all the same. It's all the same. So ACE inhibitors if there's left ventricular dysmotility, left ventricular dysfunction. And if you don't know the answer and you're on a rotation, you go, yeah, I was just going to say that. I was just going to say that. Just about to say that. So that's when you answer ACE inhibitors. Aspirin, nitrates, beta blockers. What about calcium blockers? No. 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 Now the thing is, calcium blockers are only if you can't tolerate ACE inhibitors. Beta blockers, pardon me. Calcium blockers are not as good as beta blockers. It's not like Coke or Pepsi. Bud or Miller, you know what I mean? It's not the same. It's not the same. You know, Marlboro or something else. You know, it's not the same. Beta blockers do something that calcium blockers don't. What do beta blockers do that calcium blockers do not do? Decrease mortality. That is correct. They decrease mortality, and you want to let the mortality difference drive you. Let the mortality difference drive you. Let the mortality difference drive you. And that's why beta blockers are better. ACE inhibitors are when you have congestive failure, because ACE inhibitors only lower mortality when there's the congestive failure. That's why. Let the mortality difference drive you. Aspirin lower mortality. Beta blockers lower mortality. Calcium blockers are only if you can't tolerate the beta blockers. How do I know for sure whether or not this person has Prinzmetal's angina? How do I know for sure whether this person has Prinzmetal's angina? Huh? Angiography or the history? History or ST elevation? History, ST elevation, angiography, stress testing. What's the most accurate test for any disease there is? The most accurate test for all diseases is always, huh? No, autopsy. Autopsy, but not yet. So the most accurate test, the only way to know for sure that this is Prinzmetal's angina is angiography. Angiography. I know you want it to be history. Don't look hurt like that. I hate to see you sad. You go to, oh, I don't look. I hate it when you look sad. Now the thing is, tell me, let's examine this. Okay, right? What on history? Pull back so you can see our friend here. Okay, what on history? Okay, gonna make you a star. You're gonna stick with me, son. You're gonna be a star. Okay. What on history would tell you is Prinzmetal's? Comes and goes. Intermittent pain. The problem is unstable angina comes and goes. Not related to exercise, might be unstable angina. You see? That might be unstable angina. So history of comes and goes is not sufficiently specific. So you see, this is good. This is what we do. We crawl up inside his brain and we readjust things for him individually. Okay? Okay, the intermittent nature of it, that's not enough to say, you have an intermittent history, you got Prinzmetal's. Not good enough. Right? You got your shoes on, right? But you're not walking. So, what else? What about on EKG, ST elevation? No, that's not specific enough. If they show you a person with chest pain and ST elevation, you should think of a myocardial infarction first. Rest pain. Unstable angina gives rest pain. It's not Prinzmetal's. The only way to know for sure is that you do coronary angiography and you look and you see clean coronary arteries. Clean coronary arteries on the angiography is the only way to be sure. It's Prinzmetal's. But by the way, these things about the unpredictable nature of the pain, the ST elevation, the pain at rest, that's why I told you, think of this like a support group. I know why you're saying that. Some other person in authority once upon a time did this with you. They did this with you. They went, the diagnosis of Prinzmetal's angina is determined by patients who have pain at rest. It is vasospastic angina resulting in ST segment elevation. You treat Prinzmetal's angina with calcium channel blockers to block. No, I'm sorry, I'm making eye contact. They never do that. You treat Prinzmetal's angina with calcium blockers to decrease the spasm at pain at rest and ST elevation. I know that they've said that to you. And it is true. But then they say, if you ask them, is that enough to tell you? For sure? They'd say, yeah, you got to do an angiogram to see the clean coronaries. How else do you know it's spasming? Okay? That's how you tell it's Prinzmetal's. Aspirin, nitrates, beta blockers. ACE inhibitors if there's decreased LV function. Calcium blockers only if you can't use beta blockers. What happens if you're allergic to aspirin? Wait, look up, look up. Allergies. You know how these questions go? Woman comes in, she's got a this, she's got a this, she's got a this. She's got an allergy to aspirin. She's got a normal EKG. Her stress test is positive. She works as an accountant. She loves her mother. She has 2 dogs. Blah, 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 blah. What do you do next? And you're like, I missed all that, and you give her aspirin. Oops. What do you do if somebody's got an allergy to aspirin? Ticlopidine or clopidogrel. Ticlopidine or clopidogrel. Ticlopidine or clopidogrel, or aspirin alternatives. Aspirin alternatives. Standard of care is these 3 things. Okay? Let's take a break.